Hello and welcome everyone to today's webinar for mental health professionals, Introduction to Radically Open Dialectical Behavior Therapy for Disorders of Overcontrol. I'm glad you're all here today. My name is Sasha Sicard and I am the Education and Membership Manager here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot here of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You have joined the presentation listening to your computer's audio by default. If you would prefer to join over the phone, just select phone call here in the audio panel and the dial-in information will be displayed. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. All attendees should ensure they remain muted for the entire presentation to avoid background noise and distractions. Thank you. You will have the opportunity to submit text questions at any time by typing your questions into the chat box as seen in this photo right here. We will collect these questions and address them during the Q&A sessions at the end of the presentation. For those who purchase CE or CME credit for this webinar, you'll receive an email with a link shortly after the completion of this webinar. This link will include the webinar survey and post-test questions required to receive your certificate. Please reach out to webinars@adaa.org if you do not receive this link. I would now like to introduce our speaker, Trent Codd III. Our Trent Codd III is the Executive Director of the Cognitive Behavioral Therapy Center of Western North Carolina and the VP of Clinical Operations, North Carolina for Refresh Mental Health. He treats a range of conditions, but has a particular interest in disorders of overcontrol, such as refractory depression. He is co-author or editor of Teaching and Supervising Cognitive Behavioral Therapy and Practice-Based Research, a guide for clinicians. Thank you so much for joining us. There will now be a brief moment of silence while I pass over the presenter role to him.
Okay, so the first test is, can you confirm you can hear me and see that? And
we hear you and we see it. It looks great.
Good, good. Great. Well, hey, thank you everybody for coming. I don't know everybody who's here, but I saw some names popping up as I was waiting and recognized several folks that I know, so thank you for attending. That's really nice of you. Looking forward to speaking to you about this today. Let's just jump into it. So I think in mental health, we're kind of at a crossroads, and this isn't, I don't think, a particularly new idea, and certainly not unique to RO-DBT. Several folks have had this set of concerns I'm about to present. But first, in brief, some of our existing treatments are not as effective as we would like for them to be. Just as an example, take the case of depression, where treatments consistently help about a third of individuals, with another third improving but remaining symptomatic, and the last third not improving at all. A significant proportion of people fail to benefit from treatment due to the chronicity of the illness, an extensive comorbidity problem, and pre-existing personality problems. And though I'm going to speak to all three of those issues in the talk today, in particular, I'm going to really emphasize that last one, the existence of personality variables that might be really important and haven't been optimized, we don't think, until to date. I think a lot of folks, and this is important to say, don't really, to my last point, really understand how common personality disorders really are. For example, 1 out of every 10 people in the community has a personality disorder. And related, if I could see everybody, which I can't, I would poll, I would just ask, what do you think is the most common personality disorder? And when I ask that question, typically almost everybody says borderline personality disorder, perhaps antisocial personality disorder, which is not correct. Actually, the personality disorders that are characterized by overcontrol, and I'll explain what I mean by that in just a bit, are the most common. One thing I'll sort of foreshadow now is I think the reason for that is that the borderline personality disorder, or those that we might characterize as under-controlled, tend to signal big. The magnitude of their signaling is very loud. For example, if you have a patient who self-injures, comes into your office having cut themselves, and they're bleeding in your waiting room, or like one I had who came into my waiting room once and ran and sprinted and headbutted my wall and knocked herself out. It's kind of hard to ignore that, right? It really comes to your attention. And as we'll discuss, the over-controlled personality disorders not only don't signal at that magnitude, but tend to actually really undersignal. They tend to really be understated. More on that in just a bit. Most evidence-based therapies have been tested on non-chronic and non-comorbid populations, which of course is a problem because, as you know, as a clinician, we are typically seeing clients with comorbid and chronic problems on a pretty regular basis. So just to talk a bit more about the rates of comorbidity in mental health, let's take a look at this graphic and just look at a couple of representative studies quickly. So in one study, they found that 45% of individuals with major depression also met criteria for a personality disorder. In another study, which is actually the US National Comorbidity Study, they found that 51% of individuals who met criteria for major depression also met criteria for an anxiety disorder. And for women, in another study presenting with an eating disorder, 65% of them also met criteria for an anxiety disorder. And finally, all eating disorder presentations in this particular study, also 52% met criteria for a personality disorder. This is a problem, as many people have recognized, for all kinds of reasons. And I'm going to speak to a bit more about that from this lens in just a moment. But I wanted to mention those last two slides were just to give you a sense of the context in which this treatment developed. So it's not new, although it's more recently in dissemination. I would say 2018-ish, maybe 2017 is when it really started to be disseminated, and we still have a ways to go. But it's informed by greater than 20 years of translational treatment research. And the treatment developer is Dr. Thomas Lynch, who was at Duke University for many years and who was primarily interested in standard DBT and patients with chronic emotion dysregulation problems. And so within his work in that area, he noticed that there was a subset of individuals that he would come across who seemed to have superior capacities for control, or what we're calling over-control here, and that they were not responsive to some of the existing evidence-based treatments that we had available. So taking these two things together, his sort of recognition of this population, plus the overall problems in mental health that I mentioned previously of comorbidity, chronicity, and so forth, kind of set him on this path. And I'm not going to go too far into the research on this, although I am going to speak to it a bit because I want to give you some confidence that it's evidence-based. So to date, over 350 patients have received RO-DBT in research trials. And just by way of comparison, my understanding is that standard DBT only had 24 patients go through research trials before dissemination occurred. I understand that research method standards have evolved over time and are tighter now than they used to be, but just to put that in perspective. And of course, there's been thousands clinically. Now, I do want to untangle slightly one particular trial that's known as the REFRAME trial. It's a multi-site randomized controlled trial for treatment-resistant depression. And there was a twofold aim in this particular study, which incidentally is relatively recent, was published in 2019 in the British Journal of Psychiatry. Of course, it was interested in testing the efficacy of RO-DBT relative to a treatment as usual condition, but also to examine some of the mechanisms of action for patients with treatment-resistant depression. there were 3 sites involved in the UK. Just for context, Tom left Duke and moved over to the UK, and now he's in France actually, but he was at another university in the UK for quite a while. The 3 sites were Dorset, Hampshire, North Wales. And the sample involved 250 treatment-resistant depressed patients. And one thing I'd like to emphasize is that they did not exclude some of the most difficult to treat clients within that population. So there was quite a bit of suicidal behavior, obviously a lot of chronicity. Personality disorders were not excluded, with one exception: the under-controlled personality disorders like borderline with cluster Bs were excluded, and that was only because this treatment is not designed for that cluster of PDs. So these 250 patients were, as I mentioned a minute ago, randomized into RO-DBT, which consisted of weekly individual therapy, typically an hour in duration, and a skills class that's 2.5 hours in duration, with a brief break in the middle of about 15 minutes for 7 months. And 7 months is the typical duration of this treatment. And treatment as usual could involve whatever was an approved intervention through the UK National Health Service. And I'm not an expert on the National Health Service, but my impression is that they're much better than we are in terms of the types of treatments that they allow. So I believe the treatment as usual condition to primarily consist of evidence-based treatments. Medication was also included in this. One thing you're likely to notice is that there was a greater number of participants allocated to the RO-DBT condition relative to the treatment as usual condition, and that was intentional. There was essentially a weighted randomization consideration because they were also interested in testing mechanisms, and they needed to distribute participants accordingly with that in mind. And participants were measured at 4 time points. Of course, baseline and 7 months, which, as I mentioned, is the duration of the treatment, so post-treatment, and at 2 follow-up periods at 12 and 18 months following randomization. So a couple things I want to unpack here, and the first thing is this idea of comorbidity rates that we talked about in general, but let's take a look at within this treatment-resistant population. So of this sample of 250 chronically depressed patients, only 4% of patients did not meet criteria for a comorbid mental health or personality disorder. Wow, that's just breathtaking to me. Further, 87% of patients reported at least one other mental health disorder, with the 2 most common being social phobia and specific phobia. And 79% of patients reported at least one personality disorder, the 2 most common being avoidant and obsessive compulsive PD, right? So that kind of confirms previous work about comorbidity. And just to speak to withdrawal and dropout briefly, there was a 22% of patients withdrew, which for this kind of study is relatively low. And it's important to notice that the 2 groups were roughly comparable in terms of this. And then treatment dropout from the RO-DBT condition, not study withdrawal, was 2%. And that was defined as having attended fewer than 3 sessions. Okay, so does it work? That's what we want to know. I think the brief answer is yes. And just to briefly orient you to this, and I hope that you can see my cursor here, I'm going to kind of use it as a pointer, that the orange line here is representative of the RO-DBT group, and the yellow line representative of the treatment as usual group. And you can see that we did find statistically significant group differences at post-treatment with a really large effect, with a large effect size of 1.03. And over time, RO-DBT loses its advantage in terms of statistical significance, but still maintains moderate effect sizes. I think it's also important to note that their scores did not deteriorate in the RO-DBT condition, which is suggestive of lasting or enduring effects of the treatment. Sorry, my computer froze on me there for a moment. All right, so now effect sizes have a number of uses, and I think one use is that you can compare important studies with one another, and I want to orient you to the slide. So the first thing to notice here is the study we've just been discussing, the reframe trial and the effect size of 1.03 we discussed. And right next to it, we pulled out the Cobalt study. And one of the reasons we disentangled that from some other studies is it's the most comparable one that we know of to the reframe trial. It also looked at, and many of you are probably familiar with it, looked at treatment-resistant depression, but examined the efficacy of cognitive behavioral therapy in that regard. And they reported an effect size of 0.53. So it looks like by comparison, our DBT was better. And then over here, what you see is there are a number of trials, RODBT trials for a range of problems, but in the area of chronic depression, there's three. And what you see here are the three RODBT trials for chronic depression, and the effect sizes averaged together. Of course, one of the three is the reframe trial that we've just been discussing. And when you average these effect sizes together, you get a 0.86. And then over here, we looked at some meta-analyses for comparison. And over here, you see the effect size reported in a meta-analysis of CBASP, right, 0.34. And then a meta-analysis of psychotherapies for chronic depression in general of a 0.23. And then the one I really want to point out is this one right here, is a meta-analysis of psychotherapy for non-chronic depression. And so if you look at the effect size here of 0.9 and the effect size we have over here, they're roughly the same. And I would kind of argue that in general, this group's easier to treat, right? So I think it's pretty safe to say that RODBT is evidence-based. Just further backing this up is participants in the reframe trial also self-rated their depression on the PHQ, and you can see that there was a significant difference at all time points. And then in terms of mechanism of action, one of the mechanisms that's predicted here is psychological flexibility. And this was measured with the AAQ2. And what you can see that there's a significant group differences between RODBT and treatment as usual. And also notice that it seems that psychological inflexibility improves after treatment, even after treatment. I think that's an interesting finding. Another mechanism is emotional approach coping, and this was measured with the emotional approach coping scale. And again, you can see significant differences between the two groups here. And so just briefly, some of the strengths and limitations of the reframe trial in particular is in terms of strengths, I think its generalizability to real world settings is pretty strong. For example, it included patients with difficult to treat depressions, chronic and recurrent presentations, personality disorders, high levels of suicidal ideation. And as I mentioned a minute ago, the treatment as usual condition was pretty robust. It was conducted at 3 independent sites, and I think importantly that the treatment developer nor anyone in his lab were involved in providing the treatment in this particular study. I think very important. And of course, it looked at some of the proposed mechanisms of change. In terms of limitations, they randomized fewer patients than they had hoped to. Their initial goal was 276. These patients are hard to recruit, so they ended up with 250 instead. And this is a limitation, but also I think very interesting that there was substantial variation in terms of there were therapist variables. So some therapists were more effective than others. And in fact, 12% of the variability in depression scores were attributable to this therapist difference. Why that's the case is actually being examined now. So stay tuned for those findings. So that's a very brief overview of some of the research that's related to RODBT. And in one of the recommended readings, if you want to dig into this further, I listed a paper that was published in this year, 2020, that reviews all of the existing RODBT research for a variety of problems. Okay, so now let's start to move into what it is and that kind of thing. And there's some building blocks we've got to discuss. So the first thing is to think about self-control and how we tend to think about self-control. And I think, most existing research and even culturally, I think there's an idea that there's this linear relationship between self-control and psychological well-being. And in general, the idea is that the more of it you have, the better you're doing. And, I don't think it's controversial to say that people that have self-control deficits tend to have or are more susceptible to developing a variety of problems. There's no need in reviewing that literature. That's definitely true. But the question is, though, do you continue to get additive benefits by adding or increasing or strengthening someone's self-control repertoire? And I think if you look at the data, that actually the relationship is probably not best described in linear fashion, but more in a curvilinear fashion, right? That you can have too much of a good thing, right? That really, of course, we're interested in or we're concerned about people who are on the extremes of either direction, and that being associated with various problems. Most people obviously hover in the middle here because even though we all lean one way or the other, we still have a certain degree of flexibility that enables us to modify our behavior across contexts. So that's the first thing to say. Further building on this idea is I want you to take a look at this study here, which was actually one of the earlier randomized trials of RODBT for chronic depression, or treatment-resistant depression, rather. And I just got done telling you that in the reframe trial, they intentionally excluded the cluster B or the under-controlled personality disorders. They did not do that in this case. And so just looking at the description of their sample in terms of personality disorders, what you see is that most of them are over-controlled personality disorders, 73% in this particular sample. And I'm sure it's not, I don't need to connect the dots, but because they're kind of close, but where we're going is that these personality factors are going to be pretty important, we think, if you're going to be treating or when you're treating these difficult to treat populations. All right, so there's a variety of research labs across the world that have come to, you might say, somewhat of a consensus or consistent set of findings that essentially says there's these two, I guess you could say, superordinate personality styles, or personality styles based on a common set of biotemperamental biases. And one way to talk about them is to describe them as under-controlled and over-controlled. And this is very broad brush. I just want to be clear about that. If you were to take, in DSM terms, the various disorders and allocate them to these two sort of superordinate personality styles, it might look like something like this, right? So here's what you might see in the under-controlled. And by the way, these superordinate personality styles tend to emerge pretty early in life. The research shows you can kind of identify this around ages 4 and 5, so it's pretty early on. Obviously the folks in the under-controlled, are a little more dramatic, impulsive. As kids, they're described as shy, timid. Typically speaking, they're described this way. Risk averse versus over-controlled. And I would say that if you were to think about it, this isn't like perfect. Obviously, this is broad brush, but you might think of autism spectrum disorders as the prototypical, disorder of over control, if you were to think about it in those terms. And if you were to sort of like walk back on a line, what is most characteristic, maybe the next one would be OCPD, right? And so forth. I do want to make a comment regarding chronic depression. I don't think we're saying that every chronically depressed patient is over-controlled. I think we're saying that a substantial number of them seem to be, and that the treatment for them is going to probably need to vary. So the way you would treat someone with chronic depression who is over-controlled is going to differ in important ways from someone who is chronically depressed and under-controlled. For example, if an under-controlled individual has some challenges with self-control, emotion regulation, distress tolerance, well, you're going to teach emotion regulation skills, distress tolerance skills, and so forth, right? The things that everybody knows. But if you have somebody who's over-controlled, who's probably excessively good at those things to a point where it's problematic, it doesn't make a whole lot of sense to teach them those skills, right? And it might even be harmful in some ways. What they need to learn is really kind of the opposite. They need to learn how to chill out and relax and maybe even dysregulate a tad. So that's one of the reasons why it's kind of important to think about this. And these two superordinate styles are one way of getting past. There's other reasons they're important that I'll discuss, but one way of getting past this comorbidity problem, because this seems to be a common factor and an important common factor that cuts across these disorders. So this is just a rough way of starting to think in these terms. So as you might imagine, RODBT is transdiagnostic. Interestingly, I was recently at a continuing ed event with Steve Hayes and Stephen Hoffman, and Stephen Hoffman, I think, was the one who made the comment that he didn't like the term transdiagnostic because it kind of implies you've got one foot still in the DSM system and one foot outside of it. And I hadn't considered that before, and I think the more I thought about it, the more I think that makes a whole lot of sense. And I think, I can't speak for the RODBT community, but I think that would be the way that we would think about it, is we're really thinking about that over control. That's really what we're interested in, and the DSM diagnoses aren't particularly helpful. Briefly, RODBT is informed by dialectical philosophies, you might imagine from the name. Quick comments on this. It originally, it evolved over time, right? So I mentioned that Tom was originally like a standard DBT researcher, and I think it was originally seen as this might be a variation of standard DBT for this population, and then over time, it's really developed into a completely different therapy, completely different treatment. But he wanted to retain dialectical behavior therapy in the name to honor its dialectical roots, and there is dialectical thinking in the approach still, but it is substantially different. Of course, it's got a strong behavior therapy root. Mindfulness-based approaches, the way we think about mindfulness here are substantially different. There is some overlap, but mild overlap actually. And whereas standard DBT is informed in part by Zen Buddhism, RODBT is informed by Mali Mahdi Sufism. So I'm going to hang out on this slide for a minute because there's a lot of important things here. So what is it all about? What are some of the central ideas in RODBT? Well, I think the first one is to think about social signaling. That's like one of the biggest things I want you to get from today. One of the reasons, a lot of people thought about this, how are humans who are not the most physically robust species on the planet, how is it that we come to dominate it? And there's a couple of reasons for that, I think, but one of them is the ability we form to be able to cooperate with one another. And there's a number of things that facilitated that, but one of the things that facilitated that was our ability to signal to other people that were not part of our nuclear family, you know, that we were safe, that we wanted to affiliate and cooperate with them. And one of the ways that we do that is through emotional expression. So emotions have a number of functions. One of the functions is communicative, and that is highly emphasized in RODBT. And one of the ways we communicate, or one of the primary ways, not the only way, is through our facial expressions. So it turns out that humans have more facial muscles than any other species, and we can make about 10,000 different expressions. although most humans only make about 100 or so. And because of we engage in some really briefly micro-mimicry without our awareness, typically when you micro-mimic other people's facial expressions, and that has physiological consequences for you as an individual. Super simple example, you have a child who's fallen and scraped their knee and they're in pain, they're crying, and you go to attend to the child and they're probably grimacing, right? You, without even awareness, are very likely to start to micro grimace, right? And when you micro grimace, you kind of feel, in a sense, a bit of that child's pain, right? We think that forms part of the basis of empathy. And so what we're going to find, or we're going to talk about more why this is, but with OC individuals, they tend to actually they tend to not express. There's an absence of expression. They typically have a flat face, which turns out to be the most aversive stimulus that there is, facial stimulus that there is. People around the world, cross-culturally, get anxiously aroused when confronted by an individual who has a flat face, which is, and if you think about Hollywood, they know that, right? Most of the villains in these movies have flat faces, right? The absence of, and because their intentions are not clear. And we also know that that you are liked better when you signal clearly, even if your signaling is negative in some way. So for example, blushing, right, which is involuntary. I know a lot of our socially anxious folks worry about how people are going to perceive them if they blush, but research shows that people actually like you better, right? So there's a lot of, as you'll see, there's a lot of work in RODBT with paying attention to how these clients socially signal, which is typically far from optimized, and then which leads to this sort of the second bullet point here is it makes it hard for them, or very challenging for them, to develop relationships with people. We know that being from quite a large database, being psychologically connected to other people is really important to well-being. And in fact, that's one of the main things that we're going for in RODBT is we're impacting social signaling and some other things with the main goal of getting them psychologically connected to at least one person. And it seems that when you do that, a lot of problems, things that we call emotional problems, go away. And I'll speak more to that in a minute. In a way, it's almost like we're, the metaphor is like trying to bring these individuals back into the tribe. And the initial question that comes up is how big does the tribe need to be? And the good news is that it doesn't have to be huge. It only has to be one person who's willing to put your needs above theirs. One quick point on this, you can have patients who come in and maybe you're assessing with their level of psychological connection to other people, and they might report attending lots of parties and lots of other social functions. And you can mistakenly conclude, hey, that means they've got a good support system and they're psychologically connected to other people. But that's a mistake, because a lot of OC individuals will attend lots of social functions, like substantially so, but they do so out of obligation, right? Because they're very rigid and rule governed individuals typically. They do it because they're supposed to. They're miserable while they're there, and they don't really feel connected to other people. So what matters is that connection piece, not, just dig a little deeper when you assess that kind of stuff. The next piece relates to, there's a whole neuroregulatory model that is based in part on Porges's polyvagal theory. And in the super brief version, I wish I could really unpack this at depth, but the super brief version is that there's various neurosubstrates, and broadly speaking, when one is activated, the others are offline. There can be some co-activation in some circumstances. And depending upon which one is online, so to speak, various things become available or unavailable, including, and a particular interest here is social signaling. So in essence, many of these individuals are in threat, right, which impacts the social signals and other things that are available to them. And so one of the things we want to teach them in RODBT is how to activate their social safety system so that these other things that we think are important in helping them get connected to other people then become available. And as I'll unpack in just a moment, this is very biologically based, happens at preconscious awareness. And so really, we think requires a different set of strategies than we might typically do in CBT, for example. More on that in just a bit. So one key difference, I foreshadowed this a moment ago, but I really want to emphasize it, is what we really focus on. I know I'm talking at ADAA, right? But I'm going to use the example of anorexia just because I think it makes the point really clearly. I'm not an eating disorders person. I've learned more about eating disorders the more I've gotten into RODBT because there's an indication for that. But my understanding is that most people who are treating anorexia, as you might imagine, spend a lot of time focusing on eating behavior. There's a lot of focus on that. In RODBT, in the treatment of anorexia, and of course I'm getting ready to tell you this is true for any problem that we're treating, there is no discussion of eating behavior at all, right? Because the eating behavior is not seen as the core issue. The maladaptive overcontrol is. Now, just to be clear, RODBTers are part of interdisciplinary teams, and they definitely have dietitians and medical personnel who are monitoring the safety of these individuals, and they are addressing eating, but the therapist is not. And yet, and the data are, I think, pretty remarkable actually for anorexia, which, as you might know, has been historically pretty difficult to treat. So without ever talking about eating behavior, they're achieving these really nice outcomes. So we're interested in social signaling deficits that come from their maladaptive, overcontrolled, superordinate style. And when you target that, it seems that these problems improve substantially. I alluded to this earlier, but this is worth discussing just a bit more. Overcontrol is often not recognized. The first thing I said already, which is that these are not the people who were out causing riots, getting into fights, burning things down, right? These are, those are more the under control folks. So they're less likely to come to your attention. Also, because of some of their biases, they tend to understate the level of their suffering, but we know from the data that they're suffering quite a bit. Like, you might ask an individual about one of these folks how they're doing, and they could be absolutely in the throes of hell, and they might say something like, I'm fine. And if you take that at face value, you'll miss a lot of their suffering, but that tends to be how they report things. They're very hyper detail focused perfectionists who tend to see mistakes everywhere, including in themselves. And they tend to work harder than most people to prevent future problems. And the important thing is, without making a big deal out of it. That's a big thing. They're expert at not appearing deviant, at least on the outside, which goes to what I just mentioned a minute ago. That's one of the reasons they don't come to our attention much. I have two comments in here that might be useful to know. They're more willing to let loose at home with family members or close friends, so they might seem to dysregulate in those contexts, but they won't because it's more socially acceptable to do that, and they're very rule governed. And there's also this phenomena called emotional leakage that's important to speak about. It tends to be brought on, so they can dysregulate in certain contexts, or of course they can dysregulate it, but like they're more likely to dysregulate in certain contexts. For example, there's a story that one of the patients in one of the trials, this guy used to take the bus every day to work. And on the buses, there's certain seats that are allocated for those with disabilities. And he would see somebody come on the bus every single day who did not seem to have any apparent disabilities sit in those seats. And that would infuriate this guy. But because he's over-controlled, if you were observing him in that context, you probably wouldn't pick up on the distress that he had. But this happened day after day after day after day, and eventually he blew, right? So that event is what then comes to the attention of a lot of folks like mental health professionals. And it's easy to conclude, oh, there's emotion regulation challenges here. But one of the things I want to try to sell you on is to think about the context in which, if this is reported, the context in which this happens. Could it be emotional leakage? Does it just happen in private, or does it happen out in public? So there's 4 core deficits in overcontrol, which of course are the focus of the treatment, broadly speaking, and it's the 4 that I have listed here. Lack of receptivity and openness makes it hard for them to, well, they don't seek out new situations, or they tend not to. They avoid feedback. Their ability to learn from new information is really challenged. Lack of flexible responding is an issue, and primarily meaning that there's obviously a variety of ways that these deficits can be expressed, but they're not able to modify their behavior based on the needs of the situation before them. Lack of emotional expression and awareness, and then lack of social connectedness and intimacy, and all 4 produce emotional loneliness. And so one of the main ways we talk about overcontrol is as a disorder of loneliness. These individuals are very lonely, but they can't tell you that because that's admitting weakness and fault, right? And they don't signal in ways that would help you kind of figure it out. So so now to really develop what do we mean by under control and over control, I want to hang it on this slide for a couple moments. So to talk about under control, we think it has, so first of all, what do we mean by biotemperament? That's important, right? We're specifically talking about the biological basis of 2 things in this context: how we regulate emotions and how we perceive, okay? And so so this is all biologically based, hardwired stuff. It's very important. So under control, individuals tend to be high in reward sensitivity, and essentially what that means is that they can get a sensation of reward, or very excited or excitable at very low thresholds. So it doesn't take as much relative to those who are not under control to get very excited and happy. You know, you can show them a pencil and it's like, whoa, that's a pencil, right? Like it doesn't take much. They tend to have a global focused processing style. So you might say that they tend not to see the trees, but they see the forest. They have very low or lower inhibitory control, right? Their ability to inhibit, they're impulsive, right? To lower impulses is substantially reduced relative to other populations. They tend to be very mood driven. They do things because they feel like it. Their strengths are not in planning and in delaying gratification. Interestingly, these 2 personality disorders, borderline and antisocial, borderline PD and antisocial PD, that are largely characterized as under-controlled, can also have high threat sensitivity too, which differs from the other under-controlled populations and sort of shares, that's a feature of over-control. And so what that means, if they have high threat sensitivity, that they can respond to aversive events at lower thresholds relative to like whatever the average individual might be. That helps explain some of their affective lability, right? So in a sense, they're responding more readily to rewards and aversive events. Overcontrolled, the components there are they have low reward sensitivity. So it takes a lot for these individuals to get excited or to feel pleasure. And so an example of an overcontrolled individual winning the lottery might be like, yay, you know, a little bit of an exaggeration, but not necessarily much. If you work with this population much, you know. So it takes a lot there, right? And they are very high detail focused processors, right? So they definitely see the trees rather than the forest. They're going to be very likely to pick up on mistakes, to notice the grammatical mistakes. And actually, I started doing RODBT before the manual became publicly available, and it was much nicer then, because now they will literally pull out the book and say, see, it says right here, like on page 33 in the 3rd sentence that you were supposed to do X, Y, Z. Like, you know, they've got the book memorized down to the tightest detail. High threat sensitivity, which I've already explained, and very high inhibitory control And the only thing I want to add to the high inhibitory control piece is that that's also one of the reasons that they don't signal very effectively. It looks like they're emotionless on the outside, but inside they're very anxious, typically speaking, because of their high threat sensitivity. Now, like anything, this, these biases are valuable in certain contexts. Like, these are the people you want flying the airplane that you're on, performing your surgery, building the bridges that you drive across, but you might not want to go out for a beer with them, right? So in some contexts, it's more functional than others. So why does all this matter? And I think really the important point is this first one, really, is that these biotemperamental biases impact their perception and regulation at that preconscious level in a matter of milliseconds. And just so that we're all clear, there's 1,000 milliseconds in 1 second. And most of these things that we're discussing here come online within 4 to 7 milliseconds. Now, to become consciously aware of something takes generally between 20 and 50, but usually closer to 50 milliseconds. So this stuff is happening before you can even become aware of it. It's very powerful, and they can't talk themselves out of this rigidity. You just can't. It requires a different strategy. And of course, the big issue is when it's extreme, right, there's that rigidity, there's this inability to change across context. So, it might be functional to be over-controlled to a degree at work, but what about when you go to a family, your kid's wedding or something like that, and you just generally can't relax, right? You remain uptight. That's when it becomes problematic. Very quickly, most of you are probably, I imagine, familiar with this. This is a super quick clip. Michelle's studies on self-control back in the late 60s, early 70s. As you know, the general preparation is researcher comes in, gives a child a marshmallow, and says, I got to leave for about 15 minutes, and when I come back, if that marshmallow is still there, I will give you a second marshmallow, right? And there's 2 children here, and I want you to see if you can pick out which one is under controlled and which one is over controlled. Incidentally, that researcher center just left the room. Didn't take very long. Yummy. That's me, by the way, with any kind of sugary stuff. Very excited. Yep. Yeah, that one's even got chocolate on it. Check it out. Out of sight, out of mind. So I'm sure you could pick that out pretty quickly, right? I think the key point is that you start to see this very early on, okay? And the big idea is that because it's out of awareness, these individuals unintentionally bring these perceptual and regulatory biases into social situations. And they often tend to function to isolate them from other people. So these tend to be the kids who are not picked for teams or other activities, who are ostracized in various ways, bullied, and so forth. And they often will tell you they feel that way. They feel like they're not part of the group. They feel isolated. Okay. So as I briefly alluded to, there are a range of I don't know how else to characterize them other than to say biologically based skills. They don't rely on you're trying to use higher order thinking to change some of the biases that emerge through heightened defensive arousal. And we think that that's an important thing to do before you do pretty much anything else. That's a big emphasis of this approach. So another big key I want to say is that I think most of our treatments or our intuition is to go inside the individual to look for the independent variables, I guess. So it's very common to look at, is there a distorted way they're thinking about this? Is there a lack of metacognitive awareness, or, a range of things. But in RODBT, we don't talk about any of that. Instead, we're always asking this question. We're going to their overt, publicly observable behavior how might their social signaling impact their social connectedness? It's really largely about that. So what is radical openness? Unfortunately, it's a bit like mindfulness in the sense that it's hard to describe with words and intellect. It's primarily something you come to learn through experiential practice. But in brief, it's developing a passion for going opposite where you are. So there is an approach coping element to it. But there's two things I would say, at least two things that are different than the way you might typically think about that. These individuals have a high distress tolerance level and a great superior capacity for persistence until a problem is solved. And with other contexts, that would be great to have certain patients approaching in that manner. With this group, they can really overdo it. So a lot of times we actually place limits on how long they can approach. But also the purpose behind it's a bit different too. It's to learn, to be more responsive to their environment. There is an exposure element to it, but but we'll actually, in the question, I'll talk about that. There's some important differences too. Okay, so it really is also, with this group in particular, trying to build a sense of self-inquiry that enables them to be a little more humble and willingness to admit that they're wrong. Because of their hyper detail focus processing and other biases, they're often very right about things, more than many other people. And that can lead to this sense of like, I'm more knowledgeable, I'm more right than other people, right? And so that's one of the things that and they often are correct, but not always. We try to penetrate that a bit with this set of skills. So it's not radical acceptance, and as I'm sure many of you are familiar with this concept, but as Linehan describes it, is letting go of fighting reality, and is the way to turn suffering that cannot be tolerated into pain that can be tolerated. One of the big differences here is, the RO therapist would sort of question whether or not you can really know what reality is to even let go of fighting. For example, research shows that in the span of a single breath, you can become aware of 80 or more things. And that doesn't even account for all the things that are happening in the preconscious level that we previously discussed. So this is sort of this idea that you can't really know, you're kind of going from one bias to the next. And it's the kind of the approach is a little bit captured here. We don't see things as they are, we see things as we are. Like we bring our biases with us wherever we go. And unfortunately, because of time, I'm sorry, I'm not going to be able to go too deep into this, but very quickly, we start to teach a specific way of engaging in radical openness, even on the very first skills training lesson. And this is the basic breakdown of this that becomes more elaborate over time, of course. Probably the primary takeaway to say here is because they're excessively good at regulating, and it's just automatic, more so than many other patient populations, it's harder for them to detect the cues of when they might need to occasion this kind of self-inquiry. So there's a lot of work around that. And we also try to not use like emotion words, because these patient population tends not to prefer it. Even to the point of dropping out of treatment, we tend to use things like energy. Like, do you have a lot of energy about that? That seems to be a little bit more acceptable. And again, we have them go towards whatever these cues are that they start to discriminate and teach them to ask, what is it that I might need to learn? Not as a way of regulating, which you might see in some cognitive restructuring approaches, but as a way of kind of becoming more responsive to the environment. All right. And I've essentially alluded to this. It takes lots and lots and lots of experiential practice. So sorry for going through those last two slides more quickly, just policing the time, and I want to make sure I get to the treatment structure and can answer questions. I've already briefly described what the main treatment targets are, but of course we have a couple that are targeted for decrease and some for increase. And we think that when you do that, people get more socially connected. And then, as I've said before, when they get more socially connected, A lot of the things that we call emotional problems improve substantially so. So what does the overall treatment look like? 4 components, but the first 2 are required. The second 2 are optional. So there's outpatient individual therapy, 1 hour a week. There's an outpatient skills class, which is 2.5 hours a week with a 15-minute break. And I already know what some of you are thinking. I'm a private practitioner too. How do you get an insurance company to pay for something like that? I'm going to say shoot me an email afterwards. I'd be very happy to talk to you about it. I do want to tell you that there have been a lot of modifications from the prototype to accommodate a wide range of settings. So there is a way to do this. And in my private practice, I've done this without a problem. Telephone consultation is available as it is in standard DBT, although I'm going to tell you that this patient population almost never uses it. So, you know, if that's kept you from becoming a standard DBTer, you're very unlikely to get phone calls in the middle of the night. And then highly encouraged is an RODBT consultation team, which is for practicing the skills themselves, and of course consult on cases and to make sure you're being adherent to RO radically open principles. So we do have a treatment target hierarchy here. Of course, life-threatening behaviors, you might imagine, is at the top. I do want to make a brief comment here that's important. I think the nature of the suicidal behavior with this population is a bit different because they have superior capacities for planning and delaying gratification. There is a very specific suicide assessment and intervention protocol that you can access in the main manual. I just want you to know that it's a little bit different. And then if that's not on the table, then the next thing we're interested in is therapeutic alliance ruptures. And interestingly, in most therapies, you're trying really hard not to have ruptures, right? In here, in RODBT, you actually kind of want them to happen because they're seen as a very central mechanism of change. The solution interpersonally many of these patients have is abandonment. Like they just disappear from people, including therapists. And what this helps to teach, amongst other things, is that ruptures can be intimacy enhancing. And in fact, if you haven't had several therapeutic alliance ruptures in RODBT by session 14, your therapeutic relationship is considered superficial and not a very strong one, right? There's a whole protocol for detecting and repairing ruptures in RODBT. I will tell you that one of the challenges is, again, the understatement of this population. They're not going to signal real big typically when there's a rupture. So you have to learn and get really good at discriminating when there's a rupture. But then you're going to spend most of your time focused on these OC behavioral themes. And these themes are most of the treatment describe broad classes of behavior that are very common manifestations of maladaptive overcontrol. And there's specific procedures for targeting discrete behaviors within those classes and intervening and so forth. But that's kind of how you think about it in this approach. It is carefully sequenced. This patient population, you might imagine, has a very high dropout rate. And so there's a lot of sequencing, not only to optimize the treatment, of course, but also to maximize retention. Very, very important. And briefly speaking, the first 4 sessions are orientation and commitment sessions. Those are probably the most important. And and what I have listed there are the primary things that are accomplished, but not the only things that are accomplished in those sessions. There's actually quite a bit. And then the sessions 5 through 30, roughly 30, you're focusing on the social signaling behaviors. You try to get patients into the skills class. By the way, we don't call it a group. You know, it seems that you're more likely to, this group finds class more acceptable than group. You try to get them into the skills class in week 3. So pretty early on, and it doesn't matter where the classes are in the cycle, right? You get them into the class. And I'm not going to read these to you, obviously, but here's a list of the skills. I think 99% of these are probably new skills or are new skills. The closest overlap with existing treatments might be in the mindfulness area, but there's a lot of differences there. So the most important thing in the skills class, but I'd also say even in the individual therapy, is to be pretty adherent. And what you'll find is that some of the early sessions, this is a turnoff to some people. The whole treatment is not scripted, of course, but there are definitely some scripts. Like I'm imagining that most of your training in other therapies, you were probably taught, like, don't read things word for word, right? Like, you know, kind of have this fluency about you and you're delivering a metaphor or whatever it is that you're doing. It's a little bit different here, actually, it's particularly in those early sessions, because it's so hard to retain these patients in treatment that there are some scripted portions of the session that you want to adhere to, and it's even encouraged to literally read from the manual because you're signaling to the patient, like, of course they're going to judge you like crazy for that, right? Because they're over controlled, but you're signaling to the patient that it's okay not to be perfect and not to do lots of planning ahead of time. Like, yeah, I'm reading this to you. All right. So pulling this all together is that our DBT considers it essential to address OC temperamental biases by changing physiology first. We want to target social isolation by really emphasizing social signaling skills. And we want to encourage openness and self-inquiry in order to learn from constantly changing environments, right? If you want more information, of course, you can email me. I'm very happy to talk about this stuff. But also, this is the main organization. You'll find information on other training, research studies, lots of resources. There's a blog, things along those lines. That was hard to do in an hour. Sorry. So I think I'd like to open it up for questions.
Yes, thank you so much. We are so excited that you were able to share such wonderful information. We do have time for a few questions, but if we don't get to them, you can also feel free to email webinars@adaa.org. And if we have the ability, we can send those questions over to you. Okay, so we do have one question where one of our attendees was curious about suggestions for OCPD assessment tests.
Oh yeah, I hope I do this question justice. In the manual, there's a whole protocol for assessment, and there are multiple measures. I'm pretty sure they have the names of the measures listed on that website I just referenced, but how to use them and pull them together in a battery to assess overcontrol is probably something that would take me a while to discuss. Again, I'm very happy to talk to you about it offline. Or you can pick up the manual and read about it there too.
Great, thank you so much. We have a very large question here.
Okay.
In all of the major DBT studies, it has been found to be effective in treating personality, mood, and etc. kinds of psychopathology. They would like to know, does RODBT successfully treat anxiety or, for example, social anxiety?
Yes, if overcontrol is a component of that anxiety. And what we're thinking, and you know, the data is still emerging on this, is that a large across the anxiety disorders, there's some I want to be really careful. There's some nuance here that I can't get into, but like if overcontrol is there, and it's more likely to be there if they're treatment resistant, then yes.
Okay. And one last question we'll take here, and then any other further questions can be emailed to webinars@adaa.org. Do you have any recommendations that you suggest for therapists interested in learning more about RODBT?
Oh, absolutely. Well, the recommended readings that came along with this webinar, I would totally tell you to pick up. At least 2 of them are no cost. And I would go to that Radically Open website there, and you'll see a full list of training available, including intensive training that is like 6 months in duration.
Great, thank you so much. And if anyone is interested in receiving the wonderful presentation, you can email webinars@adaa.org, and we can also provide everyone that website information as well.
It should be in your slides too, in the handouts, in the very last. page.
There we go. Yeah. Thank you, Mr. Codd, and thank you to our participants for today's training. We would like to take a moment to invite everyone to register for the 2021 Anxiety and Depression Conference on March 18th through 19th, 2021. Admission includes access to all live sessions, live Q&As, posters, and exhibits over the conference dates, extended access to more than 100 recorded presentations, and the opportunity to earn more than 50 CE or CME eligible sessions, which is wonderful. Explore more and register at ADAA.org. And if you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer, including year-long access to continuing education webinars, access to special interest groups, promotion of your practice in ADAA's online Find a Therapist database, and a significant discount to our annual conference. To view more, you can also visit our website. On behalf of ADAA and our presenter, we thank you so much for joining us today. Again, any questions can go to webinars@adaa.org. Thank you and have a wonderful day.
Thank you.